All right, I feel a bit guilty that you're stuck with me again for another hour, so I'm sorry, but I'll hopefully try and keep you awake after lunch. And what a great day it's been so far, some amazing speakers. So again, very grateful for Dr. Corker and the opportunity to speak again. So if you bear with me, what we're going to do, there's going to be about 10 minutes that's going to be pretty boring. So we're going to talk about some more of the actual research, some examples of programs. They're programs that I've been involved in, clinical programs, that have informed the program that I'm then going to talk about, which is Addi Moves. And hopefully leave you with some really practical tips around how do we implement programs in high income, high resource settings. So the first thing, I just want to acknowledge my team, and this is our group called Nexus, which stands for Nutrition, Exercise and Social Equity. We're a research group through the discipline of psychiatry and mental health at UNSW in Sydney. And I co-chair this group with my colleague, Dr. Scott Teasdale, who I'll talk a little bit about today. Dr. Scott Teasdale is a dietitian who's done an enormous amount of work around dietetics and mental illness, particularly schizophrenia. And so together our group is focused around this term of lifestyle psychiatry, which is a term that I don't particularly like, but it's where we're at and it's what's being used. So where did this all start for me and how did I end up doing this work? And I'm not going to spend long talking about this because it's now very old and there's people in this room like James and Kevin that have done far more important recent work. But for me, this is where my career started at a hospital in Sydney, Australia, a private psychiatric hospital. And it was there that I started working with people with post-traumatic stress disorder, mostly veterans, emergency service workers. And we ran this randomised control trial looking at what happens when we add exercise to usual care for PTSD. So that was where it started, and roughly the same time I was working at an early psychosis program in Bondi. People might have heard of Bondi Beach. It's one of our most famous beaches in Australia. There's a TV show that I think is far more popular here in the US than it is in Australia about the lifeguards on that beach. So this is the early psychosis program. Now, there was a few things behind this, how this work all started at that program. Around the same time that we started there was a study published looking at hippocampal volume and exercise in people with schizophrenia by a German group. So there was a lot of interest and excitement about this idea of hippocampal volume being a target for intervention. And my colleague and mentor at the time, Phil Ward, who's a neuroscientist, he wanted to replicate that study in young people with early psychosis. So we got a hold of an exercise bike and then I was brought in to try to run that project to look at can we increase hippocampal volume in young people with early psychosis. Now that picture is a picture taken inside the community mental health centre, which looks like any mental health centre, it's just a room. And when we got these bikes to do that study, we needed somewhere to put them. So we thought, okay, we'll just put them into that room and take that room. And of course, some of the clinical staff got very upset and they said, you can't take our meeting room, it's very important, we have very important meetings. This is a 2-story building. Upstairs, there was another exact same meeting room. And of course, there was never a time that both meeting rooms were used at the same time. So we did take that room, and that's what that room looks like today. And this is a fully functioning exercise physiologist-led physical activity exercise space embedded within the community mental health centre. So in addition to running the trial, looking at hippocampal volume, which we did and we published, interestingly, we found no change in hippocampal volume despite a roughly 25% increase in fitness. But then what we started looking at was the physical health of young people with early psychosis. And this was a program of work that was led by Professor Jackie Curtis, who's an amazing psychiatrist in Australia, who's dedicated her whole career to looking at the physical health of people with psychosis. So for those that don't know, a young person diagnosed with first episode psychosis, given antipsychotic medication, within the first 12 weeks of treatment, they can expect to gain somewhere between 7 to 9 kilograms. Now, what is that in pounds? I don't actually... About 20 pounds, within 12 weeks. Yeah, and that's standard. That's what we would actually expect to happen. Weight gain is normally used as a marker of medication adherence. If patients are putting on weight, they're taking their drugs, that's good. Now, of course, what happens is this lays the foundation for young people with psychosis to experience premature preventable heart disease. And ultimately, this leads to a reduction in life expectancy of somewhere between up to 20 to 25 years. So I'll just repeat that. If you have a serious mental illness, like psychosis, schizophrenia, you can expect to die 20 years earlier due to preventable premature cardiovascular disease, which is entirely unacceptable. And it's been termed a scandal of premature mortality. So this program, what we looked at was we asked the question, can we prevent antipsychotic-induced weight gain from happening? So can we intervene at day one, as soon as a young person is admitted to the service, as soon as they initiate antipsychotic medication, can we prevent that weight gain from happening? The answer is yes. This program that we called the Keeping the Body in Mind program, it had a couple of components to the intervention. One, there was this gym, led by an exercise physiologist. Two, we had Scott Teasdale running the dietetics component. Every Thursday, Scott and I used to meet the clients at the centre. We'd walk down to the local shopping centre, we'd do a shopping tour, show them how to budget, show them how to buy groceries, return to the community mental health centre, utilise the kitchen, show them how to cook a meal, do that together, and then eat that together and then hop into the gym. So diet, exercise, we also had a peer support worker, which was absolutely critical. And I met someone here today who's doing that role, which is fantastic. So the peer support, they can speak to consumers in a way that we can't. They were a vital part of the motivation. And we also had a clinical nurse consultant. So what we showed compared to a control group, now typically 75% of people who initiate antipsychotics will experience clinically significant weight gain, 75%. What we actually showed was that 75% of our intervention group did not experience clinically significant weight gain. So compared to a control group, we showed that the mean weight gain in our control group was 7.8 kilograms, exactly what the meta-analyses tell us. For our group, it was a non-significant 1.8 kilograms. These data were enough for the local health district to roll this study out across the entire district. We now have 4 services providing the Keeping the Body in Mind program across southeast Sydney. And that's recurrent funding, so about $1 million every year. So that was the early psychosis program. So that was part of the context here is the work that I had done that led to what we're trying to do at Addi Moves. More recently, this was just published very recently actually, led by our colleagues down in Melbourne, in Victoria, Adrian O'Neill. And this was a non-inferiority trial looking at online exercise and nutrition support provided by an exercise physiologist and a dietitian, compared to usual care for mild to moderate depression and anxiety. And this was during COVID. Now there's been some interesting backlash against this study from some clinical psychologists who are going on about risk and this, well, we have to deal with mental health status first, and there's actually no evidence for that. There's no reason why we can't be addressing physical health simultaneously as trying to target mental health outcomes. Now, I won't go into detail except to say that the 2 groups were non-inferior, which is very, very promising. If we think about intervening to target exercise and nutrition as first-line treatment, and the evidence is very, very strong. There was also a wonderful cost-effectiveness analysis showing that the cost of those interventions was not overly expensive either. So we've been sort of doing a lot of work trying to advocate for the inclusion of physical activity and nutrition within mental health services for a long time. There's lots of different various things here, but there's been a couple of key papers that I just want to talk about. So one is a Lancet commission that was published in 2019, led by our colleague Dr. Joe Firth, who does some amazing work based out of Manchester in the UK. And this was a Lancet commission on protecting the physical health of people with mental illness. So really addressing that inequity around the high rates of cardiometabolic syndrome, the reduced life expectancy. And this blueprint identified the issues and the actions. Some of the recommendations included, for example, that every patient should have access to physical activity and nutrition support. Mental health services should be providing those lifestyle interventions, prevention focused. So we can't wait until a young person has already put on that 7 kilograms or 20 pounds. We need to intervene from day one as soon as we can. We're currently updating this commission. There's going to be 2 additional components that I'm really excited about. We have both a lived experience consumer group who have reviewed all the recommendations. We also have a Global South advisory group who are ensuring that the updated recommendations we make are not just relevant to high income, high resource settings, that they're actually relevant all over the world. The second piece, again led by Joe, was where one of the pieces that we coined the term lifestyle psychiatry, which again it's really a horrible word. If you talk about lifestyle in a lot of places around the world, they talk about boats and playing golf or whatever else it means. But for whatever reason, this term is catching on. So this was a big review we published in World Psychiatry, looking at the relationship between those key modifiable risk factors. So physical activity, smoking, nutrition, sleep, and then common disorders, ADHD, anxiety, depression, bipolar, psychosis. The thickness of these lines represents the strength of the evidence. This was in 2020, it's already changed significantly. So for example, nutrition, we now have great work led by Felice Jacka at the Food and Mood Centre in Victoria, showing a treatment effect of the Mediterranean diet. And for those that are interested, the SMILE study was a great example of that. Some of the first data showing a treatment effect on depressive symptoms from dietary change. So altogether, it's this idea of it's being termed lifestyle psychiatry. And there's been two big pieces of work that I'll point out that are speaking to the recognition around this. So these are our clinical guidelines for the treatment of mood disorders in Australia from the Royal Australian New Zealand College of Psychiatry. And these are the most recent clinical guidelines for mood disorders. And you can see at the very first step here is lifestyle change. Yep, so that's the first thing. It was great to see that in there. Secondly, this big piece of work, another Australian, Wolfgang Marx, led clinical guidelines for the use of lifestyle-based mental health care in major depressive disorder. It's a bit of a mouthful, but this was written on behalf of the World Federation of Societies for Biological Psychiatry and the Australasian Society of Lifestyle Medicine. And here they've got the 4A model in the guidelines. They've also got a very comprehensive evidence review, assess, advised, assist, arrange. And essentially directly addressing the issue that we can't just tell patients change your diet, we can't just tell patients do more exercise, it just doesn't work. So we actually have very concrete guidelines based on very solid evidence around how and why we actually need to implement. Two things, and then I move away from all this boring stuff, but just to show the recognition of this work, it's actually very exciting. The World Psychiatric Association, WPA, in their 2023 to 2026 action plan, lifestyle research has got a key mention. They even have the physical activity for mental health and nutrition for mental health video series that they put together, which the fact that this exists is amazing. Because I can remember, probably 14 years ago when I first went to WPA and I was talking to people there about this, they'd sort of look at me like, what are you talking about? We're not at all interested. So it's really great to see that recognition. Secondly, the American Psychiatric Association, which again, I don't think have traditionally been very interested, their 2025 annual meeting, the theme is lifestyle for positive mental and physical health, which is actually quite amazing. Abstract submissions are still open, so if anyone's interested, but it's really great to see the recognition here globally of these sorts of approaches. So, and then combined with conferences like today, makes me feel very optimistic about where this is heading. All right, I got the boring stuff out of the way. So this is Addison Road Community Organisation. And this is probably where I spend most of my time when I'm in Sydney and what I'm most excited about talking about today. Addi Road, as we call it in Australia, so this is a very unique community centre in the inner west of Sydney. The site that it's on used to be government land, it used to be military site, so it was an army barracks during World War II. And the site has been leased to the Addi Road Community Centre for, I think, a $1 lease over 100 years. So they've got lots of time. The main thing Addi Road does, this is a food pantry. That food pantry feeds 8,500 people every week. Since COVID, it's been even higher. In addition to feeding people, there is a legal service, there is a gender-based violence service, there is an Indigenous health service, there's about 40 psychosocial services on site at Addi Road. The people that are coming, so we talk about the universal right to health, unless of course you have a mental illness, you come from a refugee background, you're experiencing homelessness, experiencing gender-based violence, you're food insecure, you're from a culturally and linguistically diverse community, you have a disability, or you actually fit all or some of these things. And we talk about intersectional disadvantage, where people can tick multiple boxes. And we need to be thinking about that. So really, this is who, it's people from these backgrounds that are accessing the services at Addi Road. And what we now have at Addi Road is what we call Addi Moves. And so about 20 metres away from that food pantry, we got given this building. And that was day one when I was there with Dr. Grace McEwen, and we got a couple of dumbbells from Rebel Sport, and that was our first day. Now, when I first talked to the CEO, Rosanna, about this idea, and I said, look, I want to open a gym. And she was like, that sounds ridiculous. She said, sure, you can do whatever you want, but over my dead body, will you get me in there? That was literally her words. And if I take you back to that program at the Bondi Early Psychosis Centre, where we showed that we could prevent weight gain, when the government gave us money to roll that out across the different services, we knew we couldn't just walk in and set up this exercise and nutrition service, because we knew that A, the clinicians weren't on board, and B, they would just get eaten up and the program wouldn't work. So we needed to change the culture of the services first. And so we did a big piece of work that we published called Keeping Our Staff in Mind. And what we did was we got funding and approval to provide the same exercise and nutrition intervention that we were providing patients to the staff of the mental health service. And we did that over a 12-week period. We evaluated it. We looked at the knowledge, confidence, and attitudes of the mental health staff towards these interventions. And what we showed, of course, was their knowledge changed, their attitudes changed, and their practice changed. And so we knew that we needed to do that before this happened. And so Rosanna, the CEO, was a perfect target, because when she said, yeah, over my dead body, it was like, great, you're going to be the one we're going to target. And that's exactly what we did. Now, for 9 months, we had colleagues there. Dr. Oscar Lederman was one of them, providing staff interventions in this space. So we didn't see clients. We were in the middle of a co-design process, which I'll talk about, but Oscar was just there providing staff interventions. Now, I should note that where this is located in Marrickville is also the electorate of our Prime Minister, and also some other political figures who are very well known. We had Rosanna at one point, after a couple of months, she would get up for a meeting at 1 o'clock, no matter what was happening, no matter who she was with, and she's like, this is my exercise time, and she'd go off to the gym. So the change within Rosanna was absolutely critical. It took time, but it was very deliberate, very targeted, because she is now one of our biggest advocates. It's quite funny, because she's a bit of a force. If you look up Rosanna, she's there's an article in the Washington Post. She was a development worker working in Cambodia for a very long time. There's an article on her because she shut down a Gates Foundation trial where they wanted to test a drug on prostitutes in Cambodia. And she mobilised those prostitutes to shut down that drug trial and said, go test the drug somewhere else. It's not happening here. So she's a very, very amazing woman who's done some incredible work. So having her on board and having her as an advocate is absolutely critical. And I can't stress enough how important that phase of getting the staff on board. I also mentioned that there's 40 psychosocial services on site. We provided a free program to anyone there. There's an amazing Egyptian cafe on site. The owner of that cafe was one of the clients that was coming initially, and this was free. Because again, he's serving food to everyone there. Having him on board, having him participate, understand what it's like, he can then become an advocate. Excuse me. It's currently 4 a.m. in Australia, and I'm definitely feeling that. Okay, so that's day one at Addi Moves. This is a few years later. Now, I'll just quickly point out that mural in the background there, because that was very deliberate and that was an amazing day. That was at our launch day. We had 4 refugees and asylum seekers paint that mural. One of them, his name was Moz Azimbatar. He's a Kurdish refugee who came to Australia. He was detained by the Australian government for 8 years and kept in detention, in hotel detention. Australia has a pretty brutal policy around refugee asylum seekers arriving in Australia. So Moz, when he was in detention, he's an artist. When he was in detention, he didn't have access to art supplies. What he did have was a toothbrush and coffee, and he used to paint with the toothbrush and coffee. And so Moz, together with 3 women from Afghanistan who had recently fled the Taliban, they painted that mural whatever they wanted to paint. And for them, it was reminiscent of the landscape back home in Afghanistan. Moz has gone on to be one of quite a famous Australian artist and has been recognised in one of our leading art awards, the Archibald Prize. Only a few months ago, we had an open day where we had all our referrers come through the building, which was fantastic, and also the university. I should just point out that when we set this up through the uni, it wasn't all easy. There was I got in trouble a lot from the university. They were very risk averse. They were very concerned about what if someone gets injured. They were very concerned. They seemed to have this weird obsession about me being on the front page of the paper. They kept telling me, you know, what happens if you end up on the front page of the paper? And I was like, I think they've got better things to worry about than our free gym. But I understand from their perspective, risk was a big thing. So we had to spend a lot of time in our clinical governance and getting that sorted. For me, one of the ways that I really knew we could get the university engaged, whether they liked it or not, was thinking about workforce development opportunities and practicum placements. And so for me, there's 3 pillars to what we're doing at Addi Moves. One is research. We're trying to generate knowledge around exercise and how we implement exercise programs for different groups. 2, we're trying to provide workforce development opportunities for both the exercise physiology workforce and the mental health workforce. So we're very fortunate we have some amazing partners that we team up. We get state-of-the-art training from services like STARTS, which is one of the world's leading services on the treatment and rehabilitation of trauma and torture survivors. So they have very specialised mental health practitioners who provide training to our team and vice versa. The 3rd pillar is around community service and impact. And I'm sure it's similar here, but definitely in Australia, there's this ongoing conversation that I feel they've been having for 20 years around universities and impact and wanting to move beyond papers and citations and have impact. Unfortunately, they still just revert to papers, but there seems to be this desire around impact. I don't know if it's the same story here. So it was really those 3 pillars that we had in mind around how we could structure Addi Moves. A little bit of data, because it is important, but the one thing I'll just point out here is the rebook rate. Now, for me, the fact that we have people experiencing homelessness, people experiencing food insecurity, people experiencing all sorts of disadvantage with a rebook rate over 90%, I think is quite amazing. And really a big credit to our 2 practitioners, Chiara Mastrogiovanni and Uzma Chowdhury, who are doing some amazing work. You know, some of the stories they've told me about clients they're seeing, one woman who's experiencing homelessness lives in her car with a cat. She's coming every week to see Chiara. So there's something there that she values. More recently, we've had a Tibetan monk who's experienced torture. He doesn't speak any English. Even though we had a translator for the first session with Uzma, somehow they're communicating to the point where they're not using the translator. He's coming every single week and spending an hour with Uzma. I have no idea how that's working, but it is. So again, something special around what's happening in that space. Now, importantly, a little bit more data. So the student practicum placements, and this is a key part of what we're doing. I wouldn't be able to keep the doors open without having the students there. So we're able to pay for one supervisor, but then the students come and do their placements. This is now, if we add in hours from September, it's now over 1,000 hours of student placements that we've provided. And these are placement opportunities for exercise physiologists who otherwise would have had no exposure to these people. Yep, so we're really trying to change, and the feedback we've had from the students has been amazing so far. 1 hour at Addi Moves is worth 3 hours at other placements. And one that really makes me happy, I'm very grateful for the exposure. Mental health is now what I want to do. So I think these emerging workforces that we have, we've got a huge opportunity to influence and utilise these emerging practitioners. Now, importantly, this didn't just happen. We didn't just open the door, paint a mural, put some weights on the floor, and then everything started working. We actually went through a very detailed co-design process, and this was led by my colleague, Dr. Grace McEwen, who did a fantastic work over 12 months leading this co-design work. Grace often talks about moving at the speed of trust with communities, and I think it's a really nice analogy. So Grace spent 12 months interviewing not only service providers, so people providing services to refugees and asylum seekers, but also interviewing refugees and asylum seekers themselves and having their input as part of what we were doing. I think Michelle spoke a lot about centering the voice of lived experience. That's exactly what we're trying to do. So what Grace did was that she interviewed service users and filmed it. She then went through a process of analysing that data the same way you would analyse qualitative data, and then edited that together into a movie. She then brought everyone back together and played that movie again to get another round of feedback. And what it's meant is that we now have a 25-minute video as an educational resource in exactly the words of the people that we were working with. We've also published that work in the Journal of Immigrant and Minority Health. I'll play you a little extract from some of those interviews now, keeping in mind you're going to hear from refugees, doctors, providers in about 2 minutes.
The Taliban came, they destroyed the damage. They didn't let the people work, mostly women, mostly girls. And that's why we just escaped from there. We came here, but I miss my country.
Mental and physical activity. Asylum seekers experiencing more pressure, anxiety, depression, and PTSD, and sometimes backlash, the negative factor from the whole country, the host country, and this is the backlash, negative affected to lifestyle is better.
If you, with the stress and depression, if you do the physical activity, it's not going to you the place that it has to be. It's not being helpful for you even. You have to be in the place that it feels better for you. Then you can do the exercises. So it means there is no physical activity now in Afghanistan.
So I think we need to partner up. We need to offer a service that is a bit holistic in that way, that we say, we understand that you have these basic needs, and this is a place where I can help you access those basic needs.
Personally, when I did exercise, I feel more energy. All my tiredness from my body go out, and I receive more energy, and I become so hopeful in my life and full of energy and like a strong feeling, and it's really good for mental health. When I do like gym, I feel I'm a new person. Still, I'm like so young. I'm energetic. I can do that. I can make a decide about my life when I am during my exercise, for example, at the gym, and it gives me very good feeling, and especially hopeful for the future.
It's also, I have to say, for the patients who are receptive to it, if you, again, give them a little bit, they come back in 3 months and they're like, look at all the changes that I've made, and you're like, yay! So nice, right? Because you've broken through, like it just needs that little chink.
Yeah.
And once you get there and once you show them what they can do, they will take it.
When I'm playing in the football, they will never judge me from where I am or what's my language. Like we all carry about one ball and we run for one ball and for one goal.
I love that quote about one ball. You know, for me, when I was in Bangladesh, thinking about kids playing, when I was trying to explain the analogy around sport there, I would always think if you give a kid a ball, they're going to kick the ball and they look for a friend to kick the ball too. So I love that analogy around the ball. So they were some of our participants, that's some of the interviews, and again we have a longer video that's about 25 minutes long. Now that analysis that Grace published, we also developed this infographic which covers the 6 key themes that we identified. This is freely available online. And I'll talk you through what they are. Have a longer video that's about 5 minutes long. Depends how people are feeling. It's on YouTube. You can watch it yourself, or I can play it now. We'll see. Play it now? Okay, we'll play it now. This is also covered in that podcast I mentioned, but I'll just mention what they are quickly, and I'll let Grace explain them on the video. So cultural safety, emotional safety, accessibility. So for example, it has to be free. Grace will mention, but we partnered with another charity called Thread Together, who provide us with free clothing, free sneakers. So if people don't have access to exercise clothing, we can provide that free of charge. Childcare is another big one. We absolutely are working on that now, but that's critical if we want to meet the client's needs that we're actually targeting. Support to address basic needs, we'll talk about that, but a key thing here is that these programs can be a funnel into traditional mental health services. There's an enormous opportunity that we're not realising. They're destigmatising. People attend sessions and they can then be funneled into more traditional mental health services. physical activity literacy and social and community connection. That's Grace who led this work, and I'll play that video now with Grace explaining.
We know the benefits of regular physical activity participation on mental and physical health, but those who stand to benefit the most are often the least likely to have access. So through this research, we wanted to co-design a safe and inclusive physical activity service for people from refugee and asylum-seeking backgrounds. Historically, research has been conducted for people rather than alongside the very people it's aiming to benefit. So there's a real problem here, and when you think about when researchers or policymakers say that programs don't work, often if we look at the reasons why, it's because we haven't actually asked communities what they want. So we spent over a year conducting one-on-one interviews and a series of workshops with people from refugee and asylum-seeking backgrounds, and also the people who provide services to them. So we had representatives from legal, employment and health-related supports. So we wanted to understand their experiences with physical activity programs and services, barriers and facilitators. And we did this over a lengthy 12-month period, which is really central to co-design and the principle that you move at the speed of trust. So many of the initial months were spent building relationships with the community, and then what we ended up with following the workshops were 6 guiding principles. The first guiding principle is cultural safety, where it's important that a person's identity, culture and their experience are acknowledged, welcomed and respected. And so part of this co-design process was working with people from refugee backgrounds and service providers together, and they came up with not only the 6 guiding principles but actions to address them. And so within cultural safety, some of the things that came up were around staff having the cultural capability to work with diverse groups, having women-only times and spaces, curtains on the windows, and also making sure that we respond to language barriers and using bicultural workers and bilingual workers to build trust, but also make sure that we're responding to those language barriers to accessing a traditional physical activity service. The second principle was emotional safety. So people want to feel understood and supported, which when we think about a commercial gym often isn't the case. And so people wanted us to be aware of their often traumatic past and still living experiences, and that our staff are well aware of how to respond if needed. To do this, services need to ensure that there are strong partnerships and referral pathways to existing mental health services, and that staff have all received mental health and trauma-informed training. Other strategies to create an emotionally safe facility are also around the environment, so ensuring we have colours, we have music, making people feel safe and included. The third principle is accessibility. So we need to be thinking about how do we identify and address traditional barriers to accessing services. And so a lot of the things that came up during the co-design process were around the cost of accessing physical activity services, the location and transport, how are people going to get there, and also helping to overcome barriers often facing women, including childcaring responsibilities. The fourth principle was support to access basic needs. So physical activity services need to be equipped to provide additional supports beyond just an exercise program, and this came up extensively, that people need support to access other basic needs. So people are often experiencing complex and overlapping stresses, so things like housing support, food support, and acknowledging that it doesn't need to be the physical activity service providing these additional supports, but being able to refer into programs that do. The fifth guiding principle is physical activity literacy, acknowledging the structural barriers to physical activity for people from refugee backgrounds. We need to make an effort to improve physical and health literacy. Participants wanted in-language information on the benefits of leisure time activity and to employ health professionals like exercise physiologists who can tailor activities to individuals' needs. Services should also work with community leaders and bicultural workers to improve the usage of exercise referral schemes. Also under physical activity literacy, it's important that we employ university qualified health professionals to deliver these programs, as they're able to tailor these exercise programs to people with complex needs. The sixth and final principle is social and community connection. People want to feel part of a community-based program which provides people with a sense of connectedness and prioritises joy in movement.
Also, just a big shout out to Grace, who did a fantastic job leading that work. I just want to mention that these 6 points, so we meet weekly as a team with Uzma, Kiara, Grace, our entire team, and those 6 things is what we're talking about every week. We're still in the early stages. I know we've got a lot more that we could be doing, but we're constantly changing our thinking around how do we actually address these 6 things. One thing that's really promising is that we only published this earlier this year. So the work was done last year, but already the clinical team, Uzma and Kiara, have got ideas about what we've actually got wrong here. Or not necessarily got wrong, but what we could be doing differently. So that's a really interesting process that it's already after we've seen, provided over 1,000 sessions. Now we can re-look at this and say what could we actually do differently, or what have we learnt from the clinical experience as well. Kiara, I've mentioned, who's doing a fantastic job. So Kiara did her master's with us. She's been with us for a while. She's now a PhD student. Her PhD is looking at physical activity, focusing on refugee communities. This was a piece that she led and published very recently in the Journal of Clinical Exercise Physiology, with a little infographic there talking about some of the key considerations for people in high resource settings delivering exercise services. So some of the things that have been mentioned is understanding the impact of the refugee experience, respecting the client's resources, minimising re-traumatisation, addressing basic needs, understanding systemic considerations, and protecting professionals' mental health, so looking after ourselves and the practitioners. Accessibility, so this is one of the key things. So all our resources, all our referral information, documents are in 14 languages. We also work closely with a service called Ethnic Community Services Cooperative, who are about 50 metres away from where we are. They have bicultural workers that provide services in over 50 languages. So we're very lucky to have their support, and we can use them at any time. Some of the partners, and I'll just talk about some of the projects here. So obviously the Refugee Health Service starts as the service for the treatment, rehabilitation of trauma and torture survivors. It's been amazing partnering with them. For a few weeks, we're driving groups of women from Afghanistan to Addi Moves, and we're providing services together. As a result of this, Starts have now set up their own practicum placement for an exercise physiologist that we're co-supervising. So the capacity building through the workforce there is really something I'm really excited about. Stepping Out is a charity that provides services to adult survivors of childhood sexual assault. I've mentioned Uzma, one of our other practitioners. She's now enrolled in a master's. Actually, a good story about Uzma, she was a practicum student, one of our first practicum students at Addi Moves. She was then so good that we found some money to employ her, and she's then been so good that now she's enrolled in a master's by research. So for me, that's a really exciting story. It's exactly what we're trying to achieve in terms of that workforce development. So Uzma's doing some fantastic work. Marrickville Legal, I'll just mention briefly about this because it's a really exciting project. Marrickville Legal provides free legal support to people that need it. Now, in Australia, we have a scheme called the Work Development Order Scheme. And the WDO, as it's called in short, allows people that meet a certain criteria. So it's basically people that would utilise Addi Road, people living with mental illness, people experiencing homelessness. They can, if they're given fines by the New South Wales government, they can pay off those fines by attending approved health appointments. So I'll give you an example. The classic example they give us is this 18-year-old boy with schizophrenia who was stealing tins of cat food because he couldn't pay for them. Now, of course, someone like that, he was also a refugee. Now, of course, fining someone like that doesn't do anything for society, it doesn't do anything for him. But encouraging him or providing opportunity for him to pay off that fine by attending a health appointment actually is a useful step forward. Another common one is people living in their cars. They get fined for that, they get more and more fines, and it just builds up. We have an honours student, Emma Suzuki, who's currently finished 20 interviews, including with the government and Revenue New South Wales, to understand the barriers to whether we could register Addi Moves as a WDO sponsor, which would mean that, as far as we know, this would be the first time anywhere people would be paying off fines by coming to the gym. So we've had overwhelming support, including from Revenue New South Wales. Our next step that will be happening next year is running a feasibility trial of that, which we're really excited about. Ethnic Community Services I mentioned, and the other one there is the Burmese Rohingya Association of Australia we're also working with. The next step, and I feel like my job is just trying to find money, but we're trying to resource a van like this that would be able to drive around and service all of these places with students on board. Again, with that idea of building that capacity and the knowledge that we would then build across all of these unique populations. I've mentioned Scott a few times. The next step as well in the food pantry. So I mentioned that's about 20 metres away from our gym. We are working now with Scott and the food pantry to get dietitians in there, work on healthy recipe cards, provide cooking groups, and provide this integrated service, which has always been my vision for this, that we would have dietitians at the food pantry, they would bring people into the gym and vice versa. So we've got a wonderful PhD student from Bangladesh named Afsana, who spent 5 years working in the Rohingya refugee camps around food security. We're lucky now to have her in Australia working on this issue there. So I guess overall the vision for this work is that we produce allied health graduates, so dietitians, physiotherapists, exercise physiologists, who are culturally sensitive, who are mental health and trauma informed, socially conscious and part of this global movement, and obviously Cindy, who we spoke about earlier today. You know, I think it's really interesting and exciting to see the recognition of this work and what's happening through things like the WPA, the APA, conferences like this. I've got 2 slides left, and then I'm done, and you can be free of me talking. Okay, so I do a lot of, similar to Michelle, a lot of talks for both people from a mental health background, but then also for people from the physical health, physical activity and nutrition background. And I got 2 questions here, and I used to ask these only for the specific group. So for example, if I was talking to a mental health audience, I would just use this slide. But I've actually realised it's more effective to ask both questions. So the first question is, am I a physical health informed mental health professional? And you can guess what my next slide is going to be. So we'll start here. There's 5 questions that are hopefully practical. So again, am I a physical health informed mental health professional? Number 1, do I know the WHO physical activity guidelines? They're not perfect, they're not great, they've got their issues, but it's something and it's a start. Yep. Do I know the national nutritional guidelines? Now, Scott and I have a very friendly rivalry. We're often giving each other stick about which is more important, food or physical activity. Of course, they're equally as important, but it is more than peas and carrots. There's a lot to the dietetic interventions, and I think we often underestimate that, particularly in the exercise world. 3, is my messaging psychologically safe? So what we're talking about here is, are we avoiding a focus on aesthetics? Are we just talking about weight loss? The quickest way of turning people away is let's talk about weight loss. So avoiding a focus on aesthetics, avoiding stigmatizing language, and most importantly, prioritizing enjoyment. 4, as a mental health professional, do I know how to access additional physical health support? So do I know how to refer a patient to an exercise physiologist, a physiotherapist, kinesiologist, whatever it might be, or a dietitian to access that additional support? Or am I simply saying, go and change your diet, go and do more exercises, knowing that that's not going to actually work? Finally, most importantly, and I mentioned the Keeping Our Staff in Mind project, we have very good evidence that practitioners who are physically active themselves are more likely to recommend these interventions to their patients. We need to start with staff. We need to start with ourselves. A lot of the places that we go that have limited resources or limited access to professionals, if we had one person that could provide an intervention, they would purely be focusing on staff. We wouldn't even see patients. There's been some interesting work done looking at the fitness levels of psychiatrists and the relationship between that and their referral practices. And we did a couple of those studies at the Australian Psychiatry Conference, where in the waiting room in the coffee area, we had a booth set up, we had exercise bikes, we had dynamometers, and we were doing fitness testing on the psychiatrists. And that work was led by one of my PhD students, Hamish Fibbins, who published that data, and it's being replicated now in the Netherlands and in a few other countries as well. But we absolutely need to start with staff. Finally, am I a mental health informed physical activity or nutrition professional? Mental health first aid training is a very basic thing that we can start with. It's now compulsory at our university. All of our graduates have to do this in their second year. Just like they do a normal CPR certificate, they have to do their mental health first aid. Yeah, but there's so much more we could be doing. 2, do they actively consider the unique barriers of the people they're working with? Social determinants, absolutely critical, the conditions in which people are born, live, work, play. The impact of psychiatric symptomatology and how difficult it can be for people to actually participate. We can't just tell people go and do more exercise, it's not going to work. We've got to actually address these barriers. Poor physical health, for example, the impact of medication. If we've got patients gaining 20 to 30 pounds in a few months, of course there's going to be an impact. 3, again, is the messaging psychologically safe? Are we prioritising enjoyment, avoiding a focus on aesthetics? And finally, do they know how to access additional mental health support and where their scope of practice ends? And why it's so important that we actually integrate these practitioners together and that we have the mental health professionals, physical health professionals working hand in hand. Again, just to acknowledge my group, so particularly Dr. Grace McEwen, Dr. Scott Teasdale, Oscar Lederman, Shabuj Mistry, Dr. Kemi Wright, Faradina Bakhtiar, who's a physiotherapist from Indonesia, who's doing her PhD on mental health physiotherapy. She's the only mental health physio in Indonesia who's championing that work. Afsana Anwar, who I mentioned, from Bangladesh, doing great work in food security. Carla Miranda, who without Carla I wouldn't actually get anything done. She's incredible. Chiara Mastrogiovanni, our practitioner who I mentioned. Uzma Chowdhury, the other practitioner at Addi Moves, and also Ollie, one of our RAs. So I'm very lucky to have such a fantastic group. And again, finally, just a special thanks to Dr. Corker. Thank you for arranging this wonderful event. Thank you for listening to me twice. And I'm happy to take any questions.